Chapter 8 Nutritional Assessment. As we are well aware, food and fluid are basic biologic needs. And unfortunately, deficiencies, or in the case of food, an overabundance, can all create major issues for the body. We want to explore questions about dietary intake, perceived nutrition related problems, and nutritional examination includes everything from anthropometric measurements, biochemical tests, lab results, and nutrition focused questions. It's no secret that food is getting very expensive in this country as inflation continues to amp up over the years. Other risk factors for poor nutrition is going to be everything from isolation, depression, living alone, advanced age, polypharmacy, financial limitations. Dental issues is a key one, as dental insurance and access to dentistry is another very expensive aspect of life that some people just aren't able to afford. GI disorders, multiple chronic diseases and comorbidities, substance use disorders, especially in the case of alcohol for things like B vitamins, fad diets, and inadequate access to food or cooking facilities. When it comes to anatomy and physiology, we're looking at nutrients to provide the body's calories, provide energy, build and maintain body tissues, and regulate that body processes. The basal metabolic rate is the base energy requirement, the minimum that patient calorie requirement, what they need to just to function. But this can greatly increase in the case of they're working hard. Increased output requires increased intake of calories. We're also going to talk deeply about nutrients, such as macronutrients, micronutrients, vitamins, minerals, and water. Carbohydrates are going to be our main source of energy and fiber, with 1 gram of carbohydrates producing 4 kcals of energy. Within that, fiber provides the bulk that stimulates peristalsis. Our main sources are going to be plant foods and lactose, with some being stored in the liver and muscle as glycogen, reserve energy between meals, as well as moderate amounts that must be ingested at regular intervals to meet energy demands. Our first macronutrient is going to be protein. This is essential for growth and repair of body tissues, but also serves as a source of energy. It's comprised of 20 different amino acids that combine in a number of different ways to form proteins. 10 amino acids are considered essential but not synthesized within the body. These are going to be obtained from foods with complete proteins, things like meat, fish, poultry, milk, and eggs. Foods containing incomplete proteins include things like legumes and some vegetables. It's in dealing with the combinations of proteins and combinations of incomplete proteins is where a person can get all of their essential amino acids without the use of meat, fish, poultry. Each gram of protein contains 4 kcals of energy, with 56 grams a day being required for adult men, 46 grams a day for adult women, and 71 grams a day for those pregnating or lactating females. Ideally, protein should account for 12 to 20% of all kcals. And finally, fat. Fat is going to be our main source of fatty acids and is essential for normal growth and development. Functions of fat include everything from the synthesis and regulation of certain hormones, tissue structures, providing nerve impulse transmissions, energy, insulation, and protection of vital organs. While many of us may get too much of it in our diet, it is an essential component. It also provides 2 essential fatty acids for metabolic processes, which are linoleic or omega 3 and linolenic, which is omega 6. Fat is also the body's major form of stored energy, with 1 gram providing 9 kcals of energy. Gluconeogenesis is the process that converts fat to glucose if the energy needs exceed current carbohydrate intake. If more fat is ingested than needed, it is also stored in adipose tissue. Moving on to micronutrients, especially vitamins. These are required in small quantities, with 2 groups, vitamins and minerals, being essential for growth, metabolic processes that occur continuously within the body. Vitamins are also going to be further classified as water or fat soluble. Water soluble vitamins are going to be those like vitamin B, vitamin C. They cannot be stored in the body and must be ingested in the diet daily. On the other hand, fat soluble vitamins, things like vitamin A, D, E, and K, these are stored within fat within the body. So they don't need to be consumed daily, though they do need to be consumed regularly. Each vitamin deficiency can have its own unique signs, symptoms, causes. When it comes to vitamin A, this can lead to things like night blindness, dry eyes, poor wound healing, and can be especially important for at risk populations, such as those with fat malabsorption or just a low intake. Another one's going to be in our B vitamins, especially B1, thiamine, which can cause confusion, weakness, on up to Wernicke's encephalopathy. And this is going to be especially important when we talk about things like alcoholism. Because again, remember, vitamin B and vitamin C are water soluble. And what's the first thing that happens after a person drinks a 12 pack? They've got to pee. But they're not just flushing out all that alcohol, they're also flushing out their water soluble vitamins. Often, when an alcoholic comes into the ER with symptoms, one of the first things they're going to do is put them on a banana bag, try to build up this level of vitamin B. On the other hand, vitamin B12, this is going to display as things like fatigue, neuropathy, glossitis, anemia, as it's going to be an essential building block for the hemoglobin within the body. Some at risk populations for this are things like vegans, elderly, and those recovering from GI surgeries. For vitamin C, I'm sure you've heard of the term scurvy, especially a major issue go back hundreds of years during those sailing ships where they're away from fresh food for months or years at a time. Suddenly they get that severe deficiency of vitamin C, results in things like bleeding gums, bruising, and poor wound healing. It can also occur in modern times, with at risk populations being those such as smokers or those who have a extremely low fruit and vegetable intake. When it comes to vitamin D, whenever you hear vitamin D, immediately be thinking that with calcium, as they do play an interrelated role in the building up of bones. And these deficiency signs are going to display as things like bone pain, fractures, on up to rickets and muscle weakness. This could be especially pertinent for people like the elderly or those receiving minimal sun exposure. When it comes to vitamin E, we're going to be looking at things like nerve and muscle damage, though extremely rare. And this is most at risk populations going to be fat malabsorption disorders. And finally, vitamin K. This is one we're also going to get into, especially when we start talking about anticoagulants and pharmacology. And when it comes to low vitamin K, we're going to be looking at things like easy bruising, bleeding, and just keeping in mind the major role that vitamin K plays in the creation of our clotting factors. And finally, water. Water composes 60 to 70% of the total body weight, and it's going to be a critical component for cellular function. Its constant loss requires replacements for survival and should be a continuous assessment for us throughout the hospitalization. The person requires 2.5 to 3 liters metabolized daily in both foods as well as just oral fluids. And these needs could increase in certain conditions, everything from fever, infections, gastrointestinal losses in the case of diarrhea, or respiratory illnesses. When obtaining the health history, ask the patient questions to elicit information about their current health status, past medical history, their family's history, personal and psychosocial history, as well as risk factors. You should also ask specific questions to assess about the patient's actual or potential nutritional needs. When completing a nutritional screening, we want a quick check to identify the patient's at risk for malnutrition. We want to detect early nutrition problems and decide if a full assessment is needed, or identify any potential areas for a more focused assessment. And we want to screen our patients both on admission as well as during checkups or if any clinical signs arise. Some major red flags we should be looking out for can be things like unintentional weight loss, a patient with a low BMI under 18.5, those with poor appetite, difficulty swallowing, or visible muscle and fat wasting. Other areas for assessment are going to be things like, do you have any chronic illnesses? What medications do they take? Do they take any vitamin or dietary supplements regularly? And have they noticed any unexplained weight changes, either weight loss or unexplained weight gain? When looking at their medical history, what concerns have they had regarding weight or eating problems? What measures did you take to correct these problems? Have you had any surgery that's affected your weight? What has the overall impact been on your health? And other things like, has anyone in the family had nutrition related problems? Everything from obesity, diabetes, cardiac issues, cardiovascular issues. And has anyone in your family suffered from an eating disorder, bulimia, anorexia? Also ask about the patient's activity level. Do they exercise regularly? Do they have any food intolerances, any food allergies? Do they have any issues obtaining or preparing food? Do they have a support system there to help them with that? And again, alcohol and drug use could be another major factor when, especially looking at things like malnutrition. When looking at unexplained weight loss, you should be assessing things like, when did the weight loss start? What is a normal weight for you? And what do you weigh now? Do you attribute the weight loss to any identified issue, either desired or undesired? And are they having any symptoms associated with this? Everything from fatigue, headaches, bruising, or constipation. And again, on the opposite end of that coin, looking at weight gain. When did the weight gain start? How many pounds have you gained in the last 6 months? Again, is this weight gain intentional or unintentional? And is the desired gain usually intentional because of an increase in calories, or the use of dietary supplements, or even both? Undesired weight gain may be from a decrease in activity, changes in eating habits, smoking cessation can be a common cause, fluid retention from medical conditions, and other side effects of medications such as corticosteroids or psychiatric medications. And we can't discount the role that proper dentition plays. Again, dental care is very expensive and it's not something that everyone is able to achieve. We want to look at, what problems are you experiencing with chewing or swallowing? When did this start? Are there specific types of food that could cause the most problems while eating? Is there any sensitivities to hot, sensitivities to cold? And what types of foods are you able to consume without difficulty? When looking at lack of appetite or nausea, assess what problems you're experiencing. When did it start? Is it constant or does it come and go? Is it a result of specific types of foods? And to what do you attribute this loss of appetite? Is it a known cause or is it completely unknown to the patient? We also want to look specifically what types of foods are the most difficult. There are many resources we can access for assessment of dietary intake. The USDA has the My Plate. They can help to work to determine portions of food on a typical plate, help to design a diet, build a optimal diet for that person. There's also many web-based interactive programs available. When completing our examination, again, many nutritional deficiencies become apparent through routine examination. Some findings may not even be nutrition related, such as multiple bruises that could be associated with nutritional deficiency, but could also be related to traumas or tissue injuries. For this reason, findings must be considered in association with a more thorough, detailed assessment of the patient. Other routine techniques, one is going to be the BMI chart, the body mass index. And while this chart is not perfect, it does have some flaws. It is one of the best tools we have to identify the patient's current health status. We should also assess things like general appearance, level of orientation. Does the patient appear well nourished? Are they alert? Is the body well proportioned and within acceptable weight ranges? We should also be inspecting the skin for characteristics like hydration, lesions. Skin should be smooth, elastic, without cracks or bruising. One method we could use, especially for dehydration, is tenting, where you lightly pinch on the back of the patient's hand. Well hydrated, normal skin should go back flat, normal, whereas with a patient with dehydration, it will remain pinched up and tented. We should also be assessing the hair and nails for both appearance and texture, well as any irregularities, abnormalities. Are we seeing bow lines, dentitions? Is it growing normally, healthily? For the hair, is the hair dry? We should also be looking at the eyes for surface characteristics, inspecting the oral cavity for both dentation as well as intact mucous membranes. The patient should also have full muscle strength, coordinated muscle movement, and full sensation in all extremities. When it comes to infants and children, a pediatric nutritional assessment is going to include many of the same components described for adults. Specific differences exist, such as feeding patterns, body weight. Going to be looking at plotting the weight, comparing that with percentiles to the average children of their same age. Also, looking at things like their length, head circumference on a growth chart, and observing for the presence of rooting reflex, effective sucking effort, or swallowing in infants. The nutritional assessment for older adults is essentially going to be the same as described for adults, but should also include assessment of their ability to acquire and prepare food, their social interactions, as well as general functional assessments. And again, that ability to swallow is going to be especially a top priority, especially when we start talking about patients such as post stroke, who may be at a much higher risk of aspiration. And wrapping up with obesity. Obesity occurs with greater energy intake than energy expenditure, though this can be further exacerbated by things like genetics, as well as overeating, inactivity. And overweight, obesity, and extreme obesity are going to be defined as BMIs greater than 25, 30, and 40. And just as we talked about, undernutrition is going to be categorized as under 18.5. So everything 18.5 to that 25 is going to be a normal, healthy BMI. Once we get above 25, we're looking at overweight. Over 30, we're looking at obesity. And over 40, we're looking at extreme obesity or morbid obesity in some other texts. Hyperlipidemia, or high cholesterol. This is going to be associated with elevated serum lipids, cholesterol, triglycerides, and can include dietary fats as well as genetics. Hyperlipidemia is not associated with clinical symptoms until that cardiovascular event occurs. With that high levels of cholesterol, that cholesterol slowly builds up within the body's vasculature, lining those walls as they slowly narrow. In adults, cholesterol levels from 200 to 239 are going to be considered borderline high. When it comes to protein calorie malnutrition, this refers, just as it sounds, from inadequate protein and calorie intake. It's going to be the most common form of undernutrition. Poor or limited food intake, wasting diseases, malabsorption syndromes, or issues with the GI tract. And the patient may appear thin with muscle wasting and loss of subcutaneous fat. And again, that patient's going to be considered underweight with a BMI under 18.5. Eating disorders is going to be another area we're going to get much deeper in our mental health modules next term. But there's going to be three prevalent eating disorders we need to be aware of now. The first is going to be anorexia. These are patients who just do not eat, restrict all calorie intake. Not to be confused with bulimia. These are patients who eat. They'll eat a full meal, but then they'll vomit it up before their body has a chance to digest and process all that. There's also going to be binge eating disorder. It's estimated that 9% of females and 3% of males experience anorexia nervosa at some point in their lifetime. And for our final slide, just differentiating again. When it comes to anorexia, this is going to be refusing to eat, extreme thinness, and that extreme thinness and lack of fat within the body can actually reach to the point where the body's not able to maintain heat thermoregulation. And they'll actually grow fine hair over the body called lanugo. You'll see that in premature babies who are unable to trap their body heat. In anorexia, they can actually get so thin that they begin growing that lanugo as well. When it comes to both anorexia and bulimia, one of your common ATI and NCLEX answers is going to be making sure that we're sitting with that patient after they eat. So in the case of anorexia patients, they can't immediately start exercising to burn off those calories. Or obviously in the case of bulimia patients, that they can't regurgitate their meal. And again, bulimia, that's going to be looking at everything from electrolyte imbalances, especially think about the potassium content within the stomach acid that they're constantly expelling. It can also lead to severe issues of the teeth, dentition, that stomach acids damaging the teeth, up to the point where they could even begin to get an erosion of their pharynx or esophagus from the frequent exposure to that stomach acid. But anyway, that's all we got for this chapter. See you in the next slides.